Thank you so much for coming to my presentation today. My name is Ashley Cohen. I'm the genetic counselor here at Cookeville Regional. I have a primary practice in hereditary cancer syndromes. So today we're going to learn all about genetic testing for hereditary cancers. So as a quick overview, what is genetic counseling? We'll go over that. That's a common question I get whenever I introduce myself as a genetic counselor. We'll give some presentations on hereditary cancer cases. We'll talk about genetic testing scams that have unfortunately been popping up and how to avoid those, and also address common misconceptions about genetics and genetic testing. So to start, what is genetic counseling? Again, whenever I introduce myself as a genetic counselor, people are typically like, what does a genetic counselor do? So genetic counseling is the process of helping people understand the medical but also the psychosocial implications of a genetic diagnosis. So what we do is interpret a patient's personal and family history to see if there could be the potential of there being an underlying hereditary cause for that history. Talk about inheritance pattern, how this is being passed down through the family, different testing options, the medical management recommendations that would be suggested if a patient were to test positive, different preventative measures, resources, and different research opportunities as well. And then we really focus on the counseling side of this. So how does all of that information have an impact on that specific individual? For example, when we see patients, a patient who tests positive for a gene that's increasing the risk for cancer at 18, their concerns and questions can tend to be a little different than a woman who is in her 70s getting genetic testing and what those implications mean for them. So we personalize all of that information to the specific patient and where they're at in the life stage. So genetic counselors typically have a Bachelor of Science in biology, a Master's of Science degree in genetic counseling, and we have expertise in medical genetics and counseling. So when I was in graduate school, I would say probably 75% of the education was genetics, 25% was that psychosocial counseling skills. We are board certified and licensed. I went to the University of Georgia for my Bachelor's of Science in microbiology, and then I have my Master's of Science from UAB in genetic counseling. So there are various types of genetic counseling and where patients may benefit from genetic testing. So again, today's presentation, the focus is hereditary cancer, but there is genetic testing available from a prenatal standpoint, pediatrics, adult specialty clinics, so for example like Huntington's disease or early onset Alzheimer's. Cardiology, that's also one of the big up-and-coming fields, is hereditary cardiology. And then you can see some other areas listed as well. What's also, I think, of that list on the side there, what's an interesting one is the pharmacogenetics, and that's specifically doing genetic testing for an individual to see how they might respond to certain medications. So for example, for patients who are trying to get on a drug to help with depression, we know that there's many different types of drugs, there's many different types of doses, and so genetic testing can be helpful in those cases to say, based on that person's individual genetics, what do we think that they might respond the best to? So the whole goal of the pharmacogenetics is to eliminate that trial and error process, and maybe not even eliminate it, but at least reduce that time until we find that right drug for that patient. So again, there's just many different areas that genetic counselors can practice in. And so here is an overview of what genetic counseling and genetic testing looks like. So step one, of course, schedule the patient. Number two is prepare. So what we do there is gather as much personal history and family history we can prior to that appointment, so we can do an assessment to say, based on this information, do we think there's a high likelihood of there being some underlying genetic explanation, or are we not so suspicious? During that step three, where we have the appointment, that appointment typically takes about 30 to 45 minutes, where at that time, again, we go through that patient's personal history, we'll kind of assess the family history. Then we will talk about the different genetic testing options if genetic testing is appropriate. Because as we'll see a couple slides down, not all cancer is hereditary. And so there are cases in which maybe genetic testing is not beneficial, which in a way is a good thing too, meaning that that patient has a lower risk of having one of these conditions. So we'll go through all of that history, make an assessment. We'll talk about genetic testing in detail. Typically, we talk a lot about the BRCA genes. Have either of you heard of the BRCA genes? Okay, so we'll talk a lot about those today too. But we'll talk about those genes, some other genes that can be associated with hereditary cancers. If the patient decides that they want to do genetic testing, we will do the sample collection that same day. Typically that sample collection is either going to be a blood draw or a saliva sample. And actually even nowadays they have what we call buccal samples where we get cheek cells. And so the testing itself is very, very easy. What's harder sometimes is saying, do I want to know the information I can get from this genetic testing? So we'll see a couple examples here in a couple of minutes. So we'll do the testing as long as the patient wants to move forward with that. In general, I would say insurance does a very good job of covering genetic testing for patients when we see patients meeting criteria based on their family history or personal history. Worst case scenario, if for some reason insurance does not cover genetic testing, or there's a situation in which maybe genetic testing is not necessarily is suspicious for this patient, but they still want to do the testing, we can always switch to the self-pay option of $250. And so for most patients, that's a reasonable amount, but in those situations where $250 of course is still too much, then there are different programs that are available to help reduce that cost of testing. So then it'll take about 3 weeks to get results back. So as soon as we get those genetic testing results back, we'll go over those results with the patient and their provider together, so that way they know exactly what those results mean, not only for themselves, but also for family members as well. And then for follow-up, we always like to make sure that patients are doing the appropriate cancer screenings that we recommend based on their genetic testing results. So every 2 to 3 years, we like to just check back in to make sure everything is up to date. Do you guys have any questions for me so far? Perfect. Okay, so here are some of the benefits and limitations of genetic testing. So some of the benefits is that some patients view this information very empowering, saying I can take this information now, act on it, whether that be if I have a high risk for breast cancer, I'll stay on top of my breast screening. If I have a high risk for pancreatic cancer, then there is surveillance options that could be recommended. And so for some patients, they find this information to be very empowering to take action on some of these cancer risks, relief from uncertainty. And so for some patients, particularly where we have these very strong family histories, and for years and years and years, we want to know why this is happening. Why do we have all this cancer in the family? Sometimes genetic testing can give us that answer. And so that can be reassuring for patients as well. And like I've mentioned a couple times, it can guide cancer treatment options or cancer prevention options for patients, as we'll see here in the next couple of examples. And it does have implications for family members and for family planning. And so your results could also have an impact on the family as a whole, whether that be for your children, for your siblings, parents. And so this is good information for everyone in the family. It can also help patients determine, how do I want to use this information to determine if I want to have my own biological children. And so this information, this again helps them navigate through those different aspects. Some of the limitations though of genetic testing is the psychosocial impact of these results on the patient and their relatives. So for example, in a case of an 18-year-old woman who comes in and does genetic testing and finds that she has an 80% chance to develop breast cancer in her lifetime and a 60% chance to develop ovarian cancer, that of course is very overwhelming information to receive. And so that we always kind of have to determine, how is this information going to be helpful for you now? Is it going to cause you more anxiety, or is it going to provide you information that you need to make better decisions? And so I never like to do testing in a situation in which it would cause more anxiety for that individual. That genetic testing at that point is not going to be beneficial. Sometimes with genetic testing, and actually a lot of times with genetic testing, as we'll see, we do not find an underlying genetic cause for cancer history. So a negative result does not, though, necessarily mean that they have no risk to develop a cancer. So for individuals, for example, that have a strong family history of breast cancer, they might do that testing and they come back negative, which is great news, but they still have this very strong family history of breast cancer that we cannot negate just because of a negative genetic testing result. And so again, a negative result does not necessarily reduce that patient's risk. Sometimes we do find what we call incidental findings, where if we're doing genetic testing for hereditary breast cancer, but we order a large panel test, which I'll explain here in a couple of minutes, and we find a positive result in a gene associated with colon cancer, that certainly doesn't explain that patient's history or family history of breast cancer. And so we incidentally found that they have an increased risk for colon cancer. Now, I could make the argument that that is probably a good thing, so that way we can stay on top of that colon cancer risk for them. But incidental findings can happen and can sometimes be a little confusing. We have come a long way in terms of what we know about genetics, but we are constantly learning more. So some of these newer genes, or lower genes, what we call them, they're constantly changing. And so some of these genes that patients tested positive for a year ago, they recommended breast screening. Flash forward a couple years ahead, and now we're not recommending that screening for them anymore. So these recommendations change very frequently. And so that can be hard to keep on top of what the most up-to-date information they are. And again, to that same point, everything is just changing so rapidly. So to switch gears a little bit and talk specifically about cancer genetic testing, I wanted to outline exactly scenarios in which genetic testing might be helpful for individuals, or at least for that person's family. So when we see cancer in two or more close relatives on the same side of the family, so for example, when we see two breast cancers on the same side of the family, or two colon cancers on the same side of the family, that makes me a little bit suspicious of there being some link there. When we see early ages of cancer diagnosis, so in general, for most cancers, if we're finding people diagnosed prior to age 50, that of course is a very young age to develop cancer, so it makes us more suspicious of it being hereditary. When we see individuals that have more than one type of cancer, so not necessarily that a cancer has spread to another location, but a completely different type of cancer in that same person. When we see bilateral or rare cancers in a family, so for example, if a patient has kidney cancer on both kidneys, that would make me suspicious of an underlying hereditary cause. And more rare cancers are listed a little bit below here too. So male breast cancers, ovarian cancers, pancreatic cancers, and then when we see metastatic prostate, breast, and what we call a triple negative type of breast cancer, those are all areas in which we want to investigate further to see if there's an underlying genetic link there. And then for people who have 10 or more colon polyps, that is a little suspicious of an underlying hereditary cause for their polyp history too. So this slide is always one that is a little confusing, but hopefully I can iron this out here. So all cancer itself is genetic, meaning that what cancer is and what tumors are is that it's just a bunch of mutations that happen that grow into this mass that is what we know as cancer. But not all cancer is hereditary, meaning that there's a specific gene that's being passed down through each generation that's predisposing these relatives to cancer. So here you can see there's different causes for cancer, as we know, one of which is a hereditary component, but UV radiation increases the risk for skin cancers, chemicals, so for farmers, for example, who have exposures to pesticides and fertilizers, viruses like HPV can increase the risk for cervical cancers. Smoking and tobacco use, we know, can increase the risk for lung cancers. Cell division can also, when that happens rapidly, cause these tumors too. So there's different external factors that can cause these mutations to cause cancer. But again, it's not something that you were born with that is predisposing you to those cancers there. So this is illustrating that in a little bit different way. So you can see here in the light gray area, most cancers are sporadic, meaning they happen due to chance or due to environmental factors like we had just talked about. Or a lot of the time, unfortunately, we just don't know why cancers are happening. A very small percentage of the time, about 5 to 10% of the time, cancers are hereditary, where we know there's a specific gene mutation that's being passed down through the generations. And then we have what we call familial cancer, which is right in between. So with familial cancers, we know it's probably a combination of genetic and shared environmental factors that together increase that risk for cancer. So for example, where we have a patient who has 5 close female relatives with breast cancer, everyone in the family does genetic testing and they're all negative, that kind of fits that familial category where we suspect that there's probably something genetic there just given that number of relatives affected, but because we can't find it, because they share that, close environmental factor, that kind of fits that familial cancer picture there. Any questions for me so far? Perfect. Okay, so here is a list of cancers that tend to be more on the hereditary side. Now, this is certainly not comprehensive, but I thought it was a good slide just to kind of get us started here. So the most common hereditary cancer, I guess, more when we see this cancer, more of the time it is hereditary, is ovarian cancer. So if we know any individual that has a personal or family history of ovarian cancer, even if it's just one, that is an indication to do genetic testing, because ovarian cancers, there's about a 25% chance that it is hereditary. Other cancers include stomach cancer, breast, prostate, endometrial cancers, kidney cancers. So this kind of shows the breakdown there of the percentage of breast cancer that is hereditary. We say about 5 to 10%, so you can see that there. Prostate is about the same. And so again, we use family histories as a guide to help us determine what we think, if there's that risk there. But the limitation with family histories too is that sometimes we don't have all the information. And so family histories are not 100% in that 100% predictive. So I have plenty of patients who either are adopted and we have no biological family history information, and that's okay. I have patients who don't have a close relationship with their family and we don't know any details about that family history, and that's okay. So as I talk through this, I use a lot of examples with personal and family history, but it is important to know that even people who we don't have that information, we can certainly still do testing to see if there could be something going on there, just in the absence of any known history. So here is a case example I wanted to talk through, and particularly this is associated with hereditary ovarian cancer. So my particular patient, and I'll show you here. So this is what we call a pedigree. This is what I do for every single patient that I see. It's essentially just a map of the family tree. So this particular patient is 35 years old. Circles are females and squares are males. So right here, she has no biological children, but this is her mother and this is her father here. So on her father's side of the family, this is her paternal aunt. So they are siblings here. These are her cousins. And then this is the patient's grandparents up at the top, and that's the same breakdown over here. So these are aunts and uncles here on the maternal side, cousins listed here, and grandparents up at the top. So with this particular patient, she has a maternal family history of ovarian cancer. You can see her maternal aunt and her maternal grandmother have ovarian cancer. Her mother passed away at 58 years old, no history of cancer. And then she also has a maternal grandfather that had lung cancer. So that is her family tree. So what we did, given her family history, and as we know, we talked about ovarian cancer tending to be a little bit more on the hereditary side. Given that we see two close relatives with ovarian cancer, I was highly suspicious of there being some underlying hereditary cause. Now this is a very busy slide, and I did not intend for it to necessarily be easy to see, but I wanted to at least show a visual breakdown of the testing and what we do. So here in this first column is just a huge list of the different genes that we typically test for. It's a combination of letters and numbers, and it just breaks down, again, the different gene names. But this right here I think is very interesting to take a look at, that it shows you what cancers each of these genes are associated with. So a common question I get all the time is, is there a gene for breast cancer? Is there a gene for ovarian cancer? Is there a gene for pancreatic cancer? The answer is no. My job would be a lot easier if we just had one gene for each cancer. But as you can see here, there are different cancers that are associated with each gene, in addition to the risk level. And so it can get very complex on exactly what cancers are associated with these genes and the risk. But that's part of the job, my job whenever we get results back, is to say, okay, based on this result, what is your risks for certain cancers, and to what extent, to make sure they're getting the appropriate cancer screening. So again, this is just a breakdown of all the different genes we test for. Now in this particular case, let's see, because she had a family history of ovarian cancer. So the most important column is going to be the genes here in that first one right there. So we did this testing for her. We did a cheek swab. Those results took about 3 weeks. And what we found is that she tested positive for a BRCA2 mutation. So this particular breakdown here shows you, number one, up at the top it says a positive result. Common question I get to, positive to people typically associate with a good thing. With genetic testing, it's actually a negative is a normal result. So actually in genetics, we want a negative result. A positive result means that we did identify an underlying genetic cause. So we found this specific mutation in BRCA2. This right here is just the specific mutation itself. So it's just a combination of, again, letters and numbers to show us exactly where in the BRCA2 gene did this mutation happen. And we know that it's pathogenic, meaning that it is a harmful change that's increasing the risk for cancer. So to take a quick side note here, BRCA1 and BRCA2 genes are the most common cause of hereditary breast and ovarian cancer in women. And so Angelina Jolie, and I meant to look that up, I can't remember what year she had come out with her positive result, but she tested positive for a BRCA mutation and had elected to do a bilateral mastectomy, where we proactively remove the breast tissue to reduce that risk for breast cancer as much as possible, just because we know she has a very high risk for breast cancer. So Angelina Jolie, she had her bilateral mastectomies, and then in this particular picture, this is Beyonce and her father. Her father developed male breast cancer, and as we know, male breast cancer is an uncommon type of cancer to develop, and so for that reason makes us more suspicious that it could be hereditary. He also tested positive for a BRCA mutation. Now, I'm uncertain of what Beyonce's results were or anything else in the family, but we at least know he did test positive, which would explain his history of male breast cancer, and we now know that everyone in his family would be a candidate for testing as well. So here's a breakdown of the cancer risks associated with a BRCA mutation. So the breast cancer risk for women who have a BRCA mutation is as high as 80% chance in their lifetime. The gray box here is the general population risk. So just any woman's risk to develop breast cancer is about 12% chance in their lifetime. But with a BRCA mutation, you can see it is significantly increased. The ovarian cancer risk for the general population is about 2%. With a BRCA mutation, that risk can be as high as the 40%. And then you can see male breast cancer, prostate, pancreatic, and melanoma cancer risks there. But the big ones that we think of particularly for women who test positive is that risk for breast and ovarian cancer. Now, this slide shows a breakdown of the inheritance pattern of a BRCA2 mutation. So here it shows father had tested positive, let's say for example, a BRCA mutation, and this is the mother, she has no mutation. Each of their children have a 50% chance to have that same mutation, 50% chance that they do not. The only way we can know for sure is to do testing for them. For the hereditary cancer genetic testing that we do, we typically do not test children, below 18 years old, just because these cancer risks really don't have an impact on cancer screening recommendations until adulthood. There is a condition that we'll touch on here in a little bit that is a little different, but for a BRCA mutation, for women, the recommendation is not to start breast surveillance until about 25. So we always just wait until they're 18 and older typically to do testing. But again, this shows you here, there's a 50% chance that each of their children could have this mutation, 50% chance that they do not. Same inheritance for siblings. So siblings have a 50% chance to have that same mutation, as well as their parents. And so this illustrates the need for relatives to do testing to better understand their risks as well. Now, this is a breakdown of what the recommendations are for women who test positive. So going back to our case example, we have a 35-year-old female patient that has no personal history of cancer. So the recommendation now is to ensure that she's doing what we call high-risk breast screening, which would include a mammogram and a breast MRI every 6 months, and alternating between a mammogram and a breast MRI. So that way we're screening more frequently, but also in different ways. So that way, if something were to develop, the hope is we catch that cancer very early on. So we want to ensure that she's either doing high-risk breast screening, or she could consider doing the double mastectomy as well to reduce her risk for breast cancer. From an ovarian standpoint, and I could probably make the argument, going back to her family history here, we don't see any family history of breast cancer. We see more family history of ovarian cancer. I would make the argument that it's probably a little bit more important to prioritize that ovarian cancer risk for this particular patient, given her family history. So because she tested positive, the recommendation is to have her ovaries removed between 35 and 40 years old. And so given her age, again, this would be a good thing for her to consider in the immediate future. This particular patient also did not have an intention to have any biological children. And so I do believe that that was something that she was going to be considering very soon to reduce her risk for ovarian cancer. These medical management recommendations do not apply to this particular patient, but you can see that men who test positive for these BRCA mutations, there is that risk for male breast cancer and prostate cancer, so they do recommend starting those screenings a little bit earlier for them as well. So for this case, again, this BRCA2 mutation that we detected in the patient likely explains her maternal family history of ovarian cancer. However, I always recommend testing to confirm this. I have been surprised too many times in my career to ever say anything for certain, and so I always encourage relatives to do the testing just to be sure which side of the family this is coming from. We again know this increases her risk for breast, ovarian, and pancreatic cancer, so we want to start doing risk-reducing options for her for those risks there. We talked about how she's going to start doing the high-risk breast cancer surveillance and have her ovaries removed. And then we want to ensure that we test other relatives. So again, she does not have any biological children, but we want to, in this particular case, looking at her family tree, since her mom has passed away, we want to definitely test her father, because if her father is negative, then we know for certain that it came from her mother. And so at this time, I would just encourage all relatives on both sides of the family to do testing to better understand those risks there. All right. Now, any questions or anything for me? Perfect. So the next case is a case of a 65-year-old woman. Again, this is another one of these pedigrees where we break down the patient's personal and family history. So this patient is 65 years old. She has no cancer history. She has 3 sons who are in their 30s. She has 2 sisters, and a brother. This is her mother, this is her father. Her father's side of the family is not very suspicious for any underlying hereditary cause. Her father was diagnosed with prostate cancer in the 60s. But you can see this patient's brother was diagnosed with colon cancer at 26, which of course is a very young age to develop colon cancer. Her mother was diagnosed with colon cancer in her 60s. Then you can see what the patient reported that there were 7 aunts and uncles with colon cancer and 12 cousins on mom's side of the family with colon cancer. And then you can see the patient's maternal grandmother had colon cancer in her 30s. So right off the bat, we're looking at this and we're very suspicious of there being some underlying genetic cause just because of the number of cancers that we see in the family, but also the ages that people were diagnosed. So this is that same chart that I showed you a couple of minutes ago. We do this big panel test. In this particular case, this column right here, this gastrointestinal column right here, these are going to be the most important genes that we take a look at for this patient. So her particular results came back positive for a pathogenic mutation in a gene called MLH1. Now this particular gene is associated with a condition called Lynch syndrome. Have you all heard of Lynch syndrome before? Okay. So Lynch syndrome is the most common cause of hereditary colon cancer and can be also associated with an increased risk to develop uterine and ovarian cancers in women and stomach cancers for both men and women. And so you can kind of see again a breakdown of the different cancers that are associated with Lynch syndrome. But given that patient's family history, given that we know this MLH1 mutation is associated with Lynch syndrome, this certainly fits the picture of the family history. So I'll break down here very similar to that chart that I showed you for BRCA. So the general population risk for colon cancer, you can see is about 4% in a person's lifetime. With Lynch syndrome, that risk for colon cancer is high as 60% chance. The risk for endometrial or uterine cancer is about 60%. The risk for ovarian cancer is about 20% or so. And then you can see there's other cancer risks that have a little bit lower risks there. But this is a very high risk for colon, uterine, and ovarian cancers for this patient. So the inheritance pattern for Lynch syndrome is exactly the same as what it was for a BRCA mutation. So it's called an autosomal dominant inheritance pattern. And so because this patient tested positive, and if we remember, this particular patient has 3 biological sons. And so each of her 3 sons have a 50% chance to have that same Lynch syndrome mutation. So it will be important for all of them to do testing as well. So this slide's a little busy too, but in general, the recommendation for patients who have Lynch syndrome is to do colonoscopies every 1 to 2 years. So in general, the recommendation to start colonoscopies is around age 45 and doing those at least every 10 years. For Lynch syndrome, we start colonoscopies between 20 and 25, and we do those every 1 to 2 years. So I think that goes to show how intense that screening is for these particular patients, just because we want to stay on top of that risk. If we find these polyps, if we find a mass, we want to be able to find that very early is the hope. So we do that very frequently, very early on. There is a recommendation, and this is again a very busy slide, to ultimately say, consider having your uterus and your ovaries removed to reduce the risk for uterine and ovarian cancer there. There are again some other cancers that can be associated with Lynch syndrome too, where they would recommend doing an annual urine analysis and an upper endoscopy to take a look at the stomach as well. It continues on. Pancreatic cancers can also be associated with Lynch syndrome as well. And so again, this just outlines everything that we recommend for a particular patient if they test positive. So for her, this particular mutation, again, likely explains her maternal family history of colon cancer. So let's go back up to her family tree. So again, because she tested positive, I would say with a very strong educated guess that the mutation was coming from her mother and her mother's side of the family history, but of course always recommend testing for confirmation. At that point too, I would almost certainly guarantee that her brother has the same MLH1 mutation, given that he was diagnosed with colon cancer at 26. But certainly we need to test every relative to know for sure. She has two sisters that are unaffected that would certainly need to do testing as well. Again, each of her sons have that 50-50 chance. We want to test them. And then of course this has implications for her cancer screenings like we talked about there. So let's go back to this one. All right, now, so we've kind of finished the case review. So I'm switching gears a little bit to talk about genetic testing in general. And this slide here, I wanted to illustrate that you can see, and this is not even probably a tenth of the laboratories that we know about. Some of these laboratories I use very frequently on here. There are other laboratories that I do not, but not all genetic testing is created equal. And so it's also very important to understand, what testing was done and exactly what it was looking for. And so I always want people to be aware of that if your doctor recommends testing and you say, well, I've already had 23andMe or Ancestry DNA, that testing is very different than the medical grade testing that we do here in the Cancer Center. Now, this I think is incredibly important to touch on. So this was released a couple of years ago by the Office of Inspector General, and they are warning that unfortunately there is some Medicare fraud happening with genetic testing. So what is typically happening is that scammers are offering cheek swabs to obtain a patient's either Medicare information for identity theft or for fraudulent billing. And so if anyone sees these warning signs here, where specifically for Medicare beneficiaries, where we see telemarketing calls or in public event spaces or health fairs door to door, those are all kind of warning signs, because if genetic testing is ordered through your doctor, that's a very appropriate place to get genetic testing done. But if it's being done in these other areas, I'm not going to say for certain that it is a scam, but you should be very cautious that it could be. If you hear that genetic testing can be done every month, that is certainly not true. So that would also be another red flag. So to protect yourself, and what they're doing too is they're mailing these kits to people's address, to just having them do this on their own. So if anyone gets these kits, do not submit your sample, do not provide your Medicare information. Be suspicious of anyone who offers you free genetic testing and then collects your Medicare information. And again, this should only be typically done between your physician or genetic counselor. And in those situations, I would feel very comfortable with that. And then to end, I wanted to talk about some of the common misconceptions that we see with genetic testing. So one of the common things I hear all the time, not only from my patients, but also healthcare providers, is that the father side of the family doesn't count. And that is absolutely not true. As we talked about with the inheritance pattern, we can see that 50-50 chance for all relatives. So your father's side of the family is equally as important as your mother's side of the family. I've already been diagnosed with cancer, so I don't need genetic testing. That is also not true. Genetic testing does not tell us, number one, if you do or do not have cancer, and it does not tell us if you will or will not get cancer. All genetic testing tells us is, what is my risk? Where is my level of risk based on my genetic information? Am I at a lower risk because I was negative, or am I at a higher risk because I tested positive? A positive, like we talked about too, a positive result does not mean that you will develop a cancer. It just says, again, that risk is higher. So in these cases, for patients who've already had cancer, the testing could be still helpful for them to better understand if they're at risk for other types of cancers, but also that information for their relatives as well. The common misconception I hear all the time too is broken genes skip generations. Now, this pedigree is actually that patient that I had talked about earlier with the family history of ovarian cancer. So we know this patient is positive here. We suspect that her maternal grandmother has this mutation as well, given that she had ovarian cancer, which would mean that her mother, this patient's mother, also had this mutation. These do not skip generations. Now we can see her mother was 58 and she never had a cancer, but had her mother lived to be 90 years old, would she have developed a cancer in that time frame? And so it can certainly appear that mutations skip generations because you can have these mutations and not develop cancer. So it can look like it skips, but it actually in fact does not skip generations. And then genetic testing is expensive. In the past, yes, it absolutely was. About 10 years ago, it would cost about $5,000 for BRCA1 and 2 testing, so 2 genes. Now we can do an 80 gene panel for $250. So it certainly has come a very long way in terms of insurance coverage, but also cost of testing. And then lastly, I've already had genetic testing, so I don't need it again. That's kind of true, kind of false. You don't need it again because we don't necessarily need to retest the genes that we've already tested for, but discovery of newer genes, that's where that gap kind of lies. And so in those particular cases for patients who had testing 2 years ago, no, they don't need updated testing. But for a patient who had testing 15 years ago, that would be a likely situation in which we would recommend more testing for them. So that is all I have. If anybody has any questions, I put up this cute little comic. And my contact information is here if anybody wants to reach out to me directly.